literature backs you up in terms of, you know, you need time for caseload easement, and then and there needs to be space and all that thing, even time to build relationships with the voluntary sector, etc. So there's a lot of learning in that, you know. So I'm going to move on very rapidly because I know that we're moving out of time, and we have a very valuable contribution from Leah Curlett coming up as our final presentation from the Northern Trust. And Leah was a senior social worker in Carrickfergus. You are a senior social worker in Carrickfergus Community Care Team, but you were formerly a social worker in the Community Care Team in Newton Abbey Central. And you're going to address an initiative which uses a CD approach to tackle isolation in older people. You're very welcome, Leah.
Yes, I'm Leah. So basically, my project was based on addressing loneliness and poverty. I completed my research prior to the course and seen the significant impacts that loneliness and poverty had on a person's quality of life, both physically and mentally. So this is an area that I was really interested in. I think I did focus on the age range of 65 plus, but I think it's important to note that poverty and loneliness does not discriminate. But it's not always apparent who is experiencing it. So therefore, it's so important that we screen everybody, because I think it's fair to say that we are still living in that shame culture when it comes to loneliness and it comes to poverty, and the stigma is still attached to it. So I believe us as professionals and everybody out there, we should be addressing these issues head on and fighting the conversations and not hiding behind what the real issues are. We need to dig deep to get to the problems. So I was put in contact with Joanne Morgan from the Community Development and Health Network, because this is an area that I was interested in, and she had started a piece of work in developing a poverty and loneliness screening tool. This work came from a Canadian GP who had put in place a poverty tool, which was really successful. So we adopted it to fit what we wanted to achieve. So basically, we focused the tool to be used for GPs. We decided GPs were the best professional to start the tool with, simply because the research had been released from the Royal College of GPs that indicated that 1 in 5 patients visit their GPs because they're lonely. And also there's that ongoing debate about the medical model and the social model. So as we said, the GPs will treat the part of the body that's broken, but not the whole body. And us as social workers also, due to the critical need criteria and our statutory roles and responsibilities, we were just nearly superficial in our input with clients, and if it didn't meet our criteria, they were closed. So I'm going to go through the stages of the model that we had developed. So stage 1, this was the initial screening. So we had developed the tool so that every person that came through the GP's door was screened with 3 questions to determine whether they were at risk of loneliness or poverty. These questions were: do you have trouble meeting ends meet? Do you ever feel lonely? And do you have someone who you could turn to for support if you needed it? So once the GP asked these 3 questions, they would move to stage 2. Stage 2 was gaining consent for a referral to be made to the social work team. And in this instance, it was me, because I was doing the project. Now, I tried to move it away from the whole NISA initial assessment. It was more about holistic view of their needs and having an informal chat, because I felt that's how we get the most information from clients and they start to open up. We come out with an assessment that they kind of close off. So it was about an informal chat to try and dig deeper and get to the root of the problems. This would have enabled me to then identify problems. Clients were more open, and we then moved to stage 3. And stage 3 was then me signposting them to organisations that would benefit them, finding out actually what they felt they needed and linking them in with other people that I knew within our team that liked that, or they went to different social groups. So that was the 3 stages. So I need to go to the next slide now. So the key theories that I used throughout the development of the project was networking. Networking was the biggest theory. that was a key activity for me, as I needed a hub of people that I could utilise to signpost and direct the people that I was working with to make sure that they got the right support that they needed. And the asset-based community development was key. Quite often as social workers on the ground, we get overwhelmed with our statutory roles and responsibilities, and we actually forget what is out there in the community. So sitting down with my team after completing the networking, doing the asset mapping, there was a whole change of mindset from a team perspective, that actually there is so much out there that we're not utilising. We don't have the knowledge of it. And it was interesting whenever I started that process, how there were so many organisations that were willing, that were jumping on to wanting to support me, and they were so easily utilised. But whenever you're over with all your statutory roles, sometimes you forget to dig that bit deeper. So the likes of British Red Cross, MIA, the Good Morning Scheme, Steeler Float and Support were all there. And collective leadership. So whenever we went back to the asset-based community development, the collective leadership was key. As a team, we all realised that it wasn't just one person that could change. We all had to work together. Everybody brought a strength, and everybody's strength made everything bigger. So it was the change of mindset was key. And the change theories for me, I think initially it was very frustrating, because I started in my project in one team, and trying to get DPs on board was challenging. There was that perception that, well, for me, that I had time to be doing some fancy little project and that they were too busy. But the reality of it was, we were looking holistically. We had to look at the big picture. We were receiving referrals in on a daily basis, asking for packages of care. That's all the GPs they perceived us to provide, was packages of care. And then whenever we rang clients to find out what was going on or to get more information, they were functionally independent and they wouldn't have met the criteria for a package of care. So there was that level of frustration. Why are we not digging deeper? Why are we not finding out the root of the problem? Why are we getting these referrals that present that there's no problems there? What are we looking for? The next page, or the next slide, please. So yeah, this is the SWOT analysis that I done of my project. So basically, the strengths of it initially was that we were able to strengthen our community via the asset mapping. As a team, we built a community pack resource. We were able to update that with the most updated information, what was going on in the community. It improved our personal knowledge and professional knowledge for the whole team, and building our working relationships. Instead of ringing the likes of an organisation trying to find out about them, it was good that we could actually pick up the phone and say, hi, it's Leah here, or that's Julia. There was that ownership that we knew each other, and we were all out to achieve the same thing. During my course, the anti-poverty framework was also released, which was really helpful and heightened the importance of addressing poverty. And the Royal College of GPs had also released their stats and their research in relation to loneliness, which again heightened the importance of the need to address this. And as a trust, the Northern Trust also launched their loneliness strategy policy. The weakness for me, probably the biggest weakness for me, was I started this project in one team, and I then left that team and got a new job in another team. So I kind of had to start again, because I couldn't go back to the other team to finish it, even though we were in the same trust. So the challenge here was I approached 3 GP surgeries in the local area, and 2 of the surgeries are already involved with MIA. I'm sure you've all heard of that, which are a fantastic organisation. So it was they felt it was nearly a level of duplication for them. So trying to get them on board was impossible. And also the resource limitations. Whenever I went to this team, I found that there wasn't just as much out in the community that what I had in the other area. And then the workforce culture as well. It was the mindset of the team. I went into a team that there was quite a lot of change, So I was going role reversal again and trying to change the mindset. The opportunities though was that it did build GPs' working relationships. GPs got to know the role of the social workers, and that's what the GPs still say today. The GPs come into our office now, and quite a few of the members of staff commented to me who have worked in the team for over 10 years. We've never had a GP walk into the social work office before, but that's because we've started the process of, we're the social work team, we can do this. So they now have more of an understanding of our role.
Leah, we're just in the last minute, just let you know. Yeah.
And the opportunities is the preventative work, the enablers that we've been able to connect clients ourselves. So the biggest threat was I couldn't get the GP on board for my new team, but from a multidisciplinary context, we got nurses on board, we got the social workers on board, and we got OTs on board. So those 3 questions that we identified that we used in the screening tool, all the professionals were using it now. It wasn't just because we couldn't get the GP. So they listened to my actual presentation for the course, they came along, and it actually changed the mindsets of the whole MDT team, which was really positive. So although my initial project was based for the GPs, it's actually become more beneficial for the MDT team, and for me as well as a senior social worker screening referrals that are coming into the team. I look at them on the basis of this screening tool and see if I can address these issues first before we then go and look for the statutory roles and responsibilities. And quite often on a weekly basis, it is on a weekly basis that I am redirecting, signposting and working alongside other organisations rather than having to complete a whole social work assessment. It's that more informal role. And that's the real benefit, that you're getting more out of clients whenever you just spend that time. They're people, so they are in the end of the day. And for me, it's brought us back as a team as to why we came into social work. And we're here to help people, guide people. But the most important thing is that we need them to tell us what they want. And this has helped us with that. The project didn't go the way we had planned for it to go, but it's brought many benefits to the community care team as a whole. Just one example was one lady that I'd went out to see, and I'd used the screening tool with her, and her family just wanted her to go into residential placement, and the GP was wanting that as well. But the more I sat down with her and spent time with her, the lady just broke down in tears, and she just told me, I'm lonely, I just want to be with people, I just want to get out. So like, we were able to, that family just felt putting her into a residential setting would solve all those issues, when in fact it was just masking what the real problem was. So yes, I really enjoyed the course, and it grounded me back as to why I wanted to be a social worker, and it has helped us as a team develop real change rather than those superficial reactions. And we're definitely more preventative in our role rather than reactive. And we're all about people, and I know the paperwork's always there, but we can't forget the importance of our people and what they want. That's the bulk of mine.
Leah, thank you so much for that, and I'm sorry that we actually don't have more time to hear more of that, because it's so relevant. You have a number of challenges up there which have been common to a lot of people in terms of, the engagement and the collective leadership and COVID, all of those things. So I really appreciate you